I think some of the stuff we do at the moment is not sustainable in a future healthcare world. And if we're thinking about environmental stuff, sustainability, efficiency, economics, we do really need to seriously think about what we are. I think we've got so much to offer the world in terms of healthcare, but we need to have a little bit of worry about what the future looks like and not put our heads in the sand about that.
Roger Kerry, appreciate your time. Thanks for coming to the show.
Thanks a lot,
True,
Jimmy.
true or false? This is your first time in the States?
Yes, true. True. That is true.
Like, when did you land? It's Friday now. When did you? Like, how long have you been?
The days are just all.
Yeah, no. When you're at a conference,
I got here at the start of the week, Monday or probably.
So you've been here for 4 or 5 days.
Yeah.
I mean, and you're at a conference center, which isn't a really good representation of a country because it's like all one building. But how's your experience so far?
Well, it's really good. It's just, I mean, I've not seen anything like this. We don't have things like this in England.
You guys don't have casinos and stuff like that?
Yeah, there's casinos in the airport. I got off the plane.
In the airport, yeah.
What's all that about?
You can lose $500 before you get to the hotel.
Now I know all about America.
Yeah, you gotta make sure you don't get your pockets picked. There's some people out here. Coming from across the pond, you're a professor at University of Nottingham.
Yes.
Which I need to admit, I thought was just from Robin Hood. I did not know it was a real place. I was like, that's a thing. It's a real place, though. But I felt stupid. Of course they would make a real place in Robin Hood, but I just honestly thought it was from Robin Hood.
Yeah, that's what we're famous for. Yeah.
One of the leading voices on cervical.
Cervical, yeah, don't get those mixed up.
I had a professor in PT school who was from Ireland. He's like, your cervix is in one place and the cervical spine's in the second. Don't confuse them. And I was like, got it. But when we say cervical here, we get looked at funny. But if I say cervical to you, you look at me funny.
Yeah.
All right.
Shall we just say neck?
I'll just say the neck. You're in charge. You're in charge of all things neck. Your keynote: risks and benefits of manual therapy for people with neck and head pain.
Yeah.
Reviewing the evidence on vascular risks and benefits of manual therapy. Bringing in the latest AAOMPT clinical framework and clarifying persistent myths about safety and decision making in cervical and head pain management. Let's start. You've been part of AAOMPT.
Yes.
I just want to set the stage. So AAOMPT. So wait, how do you explain AAOMPT and AAOMPT? Because Megan Donaldson did that for me before. So how do you explain it? AAOMPT is the international.
AAOMPT
international is America's chapter.
Yeah, the member organization.
Got it. Like APTA would have a state chapter. AAOMPT has AAOMPT, which is a country.
Yeah,
but there are other member countries.
Yeah, so in the UK, it's the MACP, which is the equivalent, I guess, to AAOMPT. Yeah.
Got it. You've been part of AAOMPT working group on vascular safety. What's the biggest myth about manual therapy and stroke risk that needs to go away?
That it's somehow risky, which it isn't.
Okay, well, we'll just go big.
Yeah.
Why? How does it spread? Why is that myth stuck around? Like, why can't you wipe that one off?
I don't know. I've just been talking to people here about it. Talk every day about. I don't know where that comes from. It's from the 50s when this kind of idea of stroke related to manual therapy began in medicine, and I don't know, physios picked up on it, and there's never been any substantial data to support that, and there still isn't. But what we've got now is good quality data to say, look, it isn't. If you're careful and you do the right things, there's almost no risk. And of course, there's these cases of people having a stroke after manipulation and all this business, but it's not necessarily the strokes, manipulation that's caused
correlation, causation.
Yeah, it's correlation. There's probably other risk factors. Those people were probably presenting with early signs of stroke, i.e. neck pain and headache, and then the therapist does something. They were going to have a stroke anyway, may have speeded up that process, but we've got good clinical information now and research data to say, actually, if you do this, and this, you can identify those people, and you're not going to be doing anything. You just refer them to where they need to be. Everybody else is fine. Get on with it. It's not. I'm not being pro manual therapy or pro manipulation or whatever. That's not the case at all. It's just making sense and using the evidence to say, if this was a drug, you'd just say drug A, quite safe. Drug B is a bit less safe or whatever, and that's all we're doing. It's just.
So is that how you would explain your framework to maybe students or clinicians early in their career, explain that balance who might be scared because this myth has been around for a while?
Yeah, in fact, it's going to be easy with students because they don't know anything other, and
So
if we can if we can protect them from older people, they never get to know that. And they take it on quite easily. We say, look, this is how somebody that had neck pain, lots of things you can do: exercise, advice, reassurance. Maybe this helps facilitate some movement. Just check this and this, and everything's fine. They go, yeah, okay, do that. And then the problem is they go out and in practice and
they meet older people.
Yeah, and some old person says, "Oh, that's risky. Don't they teach you not to do that and everything?" So and it's change. You know, Jimmy, change is hard to make.
So is the real risk technique or reasoning?
No, it's nothing to do with the technique. I mean, there's some techniques you wouldn't kind of want to do anyway. You know, really forceful end of range techniques, just not sensible to do that anyway. It's the reasoning. It's the not picking up the diagnosis in the first place. So if you know what to look for and think, hold on, this guy, the headache's a bit unusual, he's got these other risk factors, it's worsening a bit, it hasn't responded to other stuff, his blood pressure's sky high, neurology going on here, I'm not going to touch him anyway.
Right.
You know, just get to ED or go and see a doctor or something. And that's all but I don't know why stroke and manipulation has been highlighted. You know, we think about cancer or cord requiner or anything else, and it's straight, yeah, okay, I'll ask these cancer questions, fine. I'll ask these cord requiner questions, fine. When it comes to this, they go, oh my God, this is weird. And it's not, it's just ask these questions, and that's all it is. So it's the reasoning. The intervention itself isn't an issue, it's the reasoning.
Okay. You've described safety as not just about avoiding harm, but about enabling benefit. What do we miss when we focus only on risk?
Well, you look at what's happening around, and again, these are the conversations we have all the time. In the UK, there's big areas of the country, whole regions where the therapy leads of kind of restricting physiotherapists' use of hands-on technique for people with head pain. Same is happening in other parts of the world. Canada, individuals say, no, I don't do any of that anymore. So there's a potential moral violation of bioethic principles here of justice and beneficence and everything, because we're not providing the treatment, the evidence-based treatment that could help somebody. So I think that's more of a risk than tiny, almost zero risk of something adverse happening for a treatment. And we know that musculoskeletal pain is, lead global burden, and we know that neck pain and headache are one of the big players in that. So this is big scale stuff. We're almost facilitating chronic pain by not addressing people with the tools that we've got, that the evidence says is useful to help them with. So yeah. I think that's more of a problem. We can deal with just check they're safe, but we've got to change that narrative about, look at the way you rehabilitate an ankle. You don't just rub it and send them home. You jumping up and down, get them running around, zigzagging, this, that, and the other, until they're back to performance. With neck pain, we go, oh, here's an exercise sheet, and that's it. I don't want to see you again.
Right.
And we're falling well short of good practice.
Okay. You travel the world, even coming to Reno, teaching about this. Welcome to Reno, by the way. Welcome to the U.S. What's the most surprising cultural difference in how manual therapy safety is taught or perceived in places that you've been? Like, I love when I meet people like you, because you're bringing this familiar knowledge to other places, and you've got to maybe sometimes change your delivery based on who you're talking with and what they know.
Absolutely. It's really important to tune in, and that's why it's nice to be around a conference for a little while to tune in and get a vibe and sit in on some other talks and think,
know your
how we got to address this.
Read the room.
Yeah, absolutely read in the room. How I'm going to not upset everybody so immediately there's a barrier there and they're not going to listen to what you say.
Get all defensive.
Yeah, because it would be easy to go, you're all losers.
This is right.
This is right. You're wrong. Yeah.
I'm out. Buy my book. See ya.
Exactly. That isn't going to work. And so it's like tuning in with people's vibe. But you're absolutely right. The perception, the understanding, the beliefs, the attitude about this kind of stuff varies. globally, but also locally as well. I could go to one part of England and such down
Sure.
south it's another. Continental Europe, France, Italy have got a very different perception of this than they have in Norway and Sweden and things. So it's really odd, and I don't know why there's no need for that. It's just like, here's some information. It applies to everybody. Just do it. But I don't know.
Is that why coming to something like AAOMPT with, I don't know, 1,500 or 2,000 people is such a great thing? Because you're going to affect a lot of different people from a lot of different places, and hopefully those people go back and tell their colleagues.
Exactly. We've got we're almost preaching to the converted here, because they've switched on bright people who've self-selected to come to this high level conference. So that's the pitch, to get them to then roll that on and scale it up as much as they can. Yeah.
If you could rewrite one sentence in every manual therapy textbook tomorrow, what would it be?
Don't worry so much about some weird details about manual therapy and some of the history. We know it's a useful adjunct to good care package,
right?
And we know how you can be safe and comfortable and efficient. You don't need to stress out about some of the old rules that kind of really put people off using it, and think, I don't understand all that really complex stuff about this law and that law and this grade and that grade, so I'm not going to do it. You actually don't need any of that. You just need good safe handling, and you need that good functional understanding of anatomy and everything else, but you can get on with this fairly easy. It doesn't need to be put on a pedestal and made to be something special. It's just exercise, education, manual therapy. They're all fine. They're all the same. They're all good.
How long have you been a physio, ballpark?
20 odd years, 25, 6, 4.
What's
7,
something
3.
that was a fact when you began that is now looked at like, oh yeah, we jumped the gun on that? Or
Things like that. You remember concave convex law, stuff like that.
I was learning that 10 years ago.
We were taught that sort of stuff.
That
and
was
this
like
rule and
that was
rule.
Like law. That was like gravity 10 years ago.
Yeah.
Not so much.
Well, 20 years ago it was as well. So it's a bit worrying that 10 years ago it's still like that. But stuff like that you had to learn and learn and remember, and let that dictate something like, this is the way you move somebody's knee or something. That was absolute fact when I trained, and if you got that wrong, you didn't pass your exam.
Right. Or you're undoing the thing, or you're making it worse.
You're facilitating flexion, not extension.
I remember standing there like with someone thankfully face down, and then like doing like this and looking and saying, wait, which the convex, and then doing a little mnemonic in my head and going like, I'm pretending I know what I'm doing, and then 5 minutes in, them saying, it's my other shoulder, right? It's like, absolutely. What we do is we do it on this shoulder to really get a good feel. Then we go to the other side to make sure that I can feel the difference.
Great save there.
Great save. We have something called the parting shot. Your last chance for a mic drop moment or a soapbox statement. What's one thing you'd want to leave the audience of people listening to this, not just here at the conference, but what do you want to leave with them?
I think we need to think about where we're going in the future, and just we need to remain evidence-based, person-centered, but we need to think big. We need to upscale what we do.
What's that mean? What's think big?
Communities, population level stuff.
Okay.
I think some of the stuff we do at the moment is not sustainable in a future healthcare world. And if we're thinking about environmental stuff, sustainability, efficiency, economics, we do really need to seriously think about what we are. I think we've got so much to offer the world in terms of healthcare, but we need to have a little bit of worry about what the future looks like and not put our heads in the sand about that.
All right. I love it.
I don't know what it looks like.
Words from Roger Kerry. Well, good. You don't have. That's the way you hedge the bets. Be like, we need to do this. How do we do it? That's on someone else.
Yeah.
And then you look like a genius when it happens because you called it. Well, hey, appreciate you coming by for a hot minute here with us at the conference. Enjoy Reno. We'd love to have you back in the States at different places, because there are other places outside of just Nevada. Nevada is fantastic, but there are other places outside of a casino. This isn't just what the...
Well, there's a Wendy's outside as well.
We do have a lot of Wendy's, but we do have other things too, Roger Kerry, appreciate your time, man.
Thanks, Jimmy.
Thanks, man.
It's been a pleasure.
Thanks for listening to Hands On, Hands Off, the official podcast of AAOMPT. Subscribe now so you never miss an episode, and connect with us at aompt.org or at AAOMPT on social. Opinions are those of the guests and not official AAOMPT policy. See you next time.